In Karnataka, a South Indian state, program science has been successfully implemented by the Karnataka Health Promotion Trust in its programs focusing on HIV prevention among female sex workers. The impact of engaging with most at-risk populations such as female sex workers, men who have sex with men, transgenders, and people who inject drugs is well known. Evidently, this calls for involvement of a mix of programmers and scientists in program planning and design, implementation, monitoring, and evaluation.
When we refer to populations that we engage with, while most at-risk populations are the primary focus of the program, we do not restrict our interventions only to this group. We also target healthcare providers, social protection agencies, legal and enforcement systems, and religious leaders. Specifically, within the health system, we map facilities and providers, explore their profiles and healthcare practices, and target those sites which have the potential for maximum influence and impact, both because of the high volumes that they cater to, as well as because of the preference that communities have to access them.
Program design and planning. To understand the size and distribution of the population of female sex workers and optimize the allocation of program resources, an initial mapping was conducted with the support of community members. The mapping provided information on hotspots where female sex workers usually solicit for clients and their typology. It also assessed HIV-related risks and vulnerabilities among them. Mapping led to micro-planning, site analysis, and opportunity gap analysis to improve outreach and enhance the delivery of services.
Mapping ಮಾಡಿದ ನಂತರ ನಮಗೆ ಏನು ಗೊತ್ತಾಯ್ತು ಅಂತಂದ್ರೆ ಹೈ ವ್ಯಾಲ್ಯೂಮ್ ಸೆಕ್ಸ್ ವರ್ಕರ್ ಯಾರು, ಮೀಡಿಯಂ ವಾಲ್ಯೂಮ್ ಯಾರು, ಲೋ ವ್ಯಾಲ್ಯೂಮ್ ಯಾರು. ಸೆಕ್ಸ್ ವರ್ಕರ್ ಒಳಗೆ ನಮಗೆ ಹೈ ವ್ಯಾಲ್ಯೂಮ್, ಮೀಡಿಯಮು, ಲೋ ವ್ಯಾಲ್ಯೂಮು ನಮಗೆ ಕಂಡು ಬಂದು ಅವಾಗ ನಾವು ಏನು ಮಾಡಿದ್ವಿ ಅಂದ್ರೆ ಪ್ಲ್ಯಾನಿಂಗ ಹೈ ವ್ಯಾಲ್ಯೂಮ್ ಸೆಕ್ಸ್ ವರ್ಕರಿಗೆ ಏನೆಲ್ಲ ಸರ್ವಿಸಸ್ ಕೊಡಬೇಕು, ಲೋ ವ್ಯಾಲ್ಯೂಮ್ ಇದ್ದವ್ರಿಗೆ ಏನು ಸರ್ವಿಸಸ್ ಕೊಡಬೇಕು, ಮೀಡಿಯಮ್ ಇದ್ದವ್ರಿಗೆ ಏನು ಸರ್ವಿಸಸ್ ಕೊಡಬೇಕು ಅಂದ್ರೆ ನಮಗೆ ಒಂದು ಕನ್ಫರ್ಮ್ ಆತ ಒಂದು ಮ್ಯಾಪಿಂಗಿಂದ.
Stigma and discrimination, lack of education, skills, poverty and low social standing, lack of power over resources, lack of access to health services, and other social entitlements were among the key issues identified among female sex workers. To address the key challenges and barriers, street plays, folk and visual media were used. A program science framework was developed by integrating empowerment and social equity into the program structure. This catalyzed the community mobilization to change the equations of power within, power with, and power over at the individual, group, and population level.
We started learning from the community that violence is an issue. The difficulty in getting social entitlements, the difficulty in accessing the services, so in the general public domain. So these are the issues which is not part of our program. So this is all in the process where community used to bring up and we try to address as part of the program. We are involving community and designing the program on the need of the community. I think that is something which is long-term sustainable process which we have followed as part of program science approach.
Monitoring and evaluation. Structured formats were used for rigorous program monitoring at various levels. Visual peer cards and crisis cards to document outreach activities and crisis responses were used since majority of the peer educators were illiterate. For evaluation purpose, 3 rounds of integrated biological and behavioral assessments and 5 rounds of polling booth survey were conducted to capture the changes in the outcomes. The evaluation of the program found a substantial reduction in the prevalence of STI and HIV among the FSWs due to the increased condom use with partners. Moreover, Districts with stronger community-based processes and higher community participation led to more empowerment among the FSWs compared to other districts which didn't have those community-based processes.